Do we know if, like, are we expecting Karen or?
Karen's right here.
Oh, yeah, oh. Okay, we will call the meeting to order. And then we'll do a roll call. Jeffrey Beam,
Yes.
Ralph Harrison,
Yes.
Lois
Gritzmacher.
Here. Karen Powers,
Here.
Eric Smiltmeek, Toby Vandenhoeven,
Here.
and then Joshua Belleville
Here.
and Paula McNeil. I think that's a form.
Yes.
Okay, and could I get a motion for the approval of minutes?
I move to accept the minutes as presented.
Move to approve.
All those in favor?
Aye.
All those not in favor? They are approved. Public comment period. There's nobody in the room, but I see two, I don't know if
Those are all.
Oh, they are
Yeah,
staff.
health
Okay.
people.
We'll move on then to our business. We will welcome our new board member, Joshua.
Good
You go by
morning.
Joshua.
Josh, thanks for having me, everybody.
Do you want to tell people anything about yourself?
Oh, sure, why not? Okay, so I'm a chiropractor. Today is actually my 6th year. Technically, I graduated 6 years ago, so I'm pretty excited about that. And I'm really happy to be on this board. In chiropractic school, we had a class and we talked about, joining government and making change. And I sat in that class and I was like, that'd be kind of cool someday to be a part of that and be on a board of health. And I really thought it would never happen. And then here I am sitting here today. So I think that's kind of cool. So I'm excited to be on here and be a part of making Winnebago County a healthy community. So thanks a lot for having me.
Thanks for being here.
Budget transfer. It's very weird not to have Doug.
I'm poor substitute. Yeah, so we have two budget transfers that will require a vote. The first one is for $1,600, the lead abatement program, and I think Ann can give you some historical context about that.
Sure, this is just an increase in grant funding from what was originally available in the grant. So they need to make this change. We have currently 9 properties enrolled in that program. And 4 in the approval process, 2 are complete, and the work is scheduled on 2 of those. So it's just funding for the lead abatement on houses.
Any questions? So can I get a motion?
I go to for the budget transfer.
Second.
All those in favor?
Aye.
All those not in favor? I assume I have to sign this before we leave.
I believe so. The second budget transfer is for $80,083 for the harm reduction program vending machines. Will also require a vote, and Ashley will give a background on that.
So this is a grant we were awarded for public health vending machines, actually, is what the title of the grant is, through the Wisconsin Department of Health Services. So the funds would cover 2 vending machines that we have an intention to place them in the alcove outside of CAB here and then in Neenah Human Services. So this grant application was a partnership between the Health Department, Human Services, and the DA's office. And so these vending machines would include things like Narcan and kind of basic needs, hygiene kits, things like that, that we want folks to be able to access outside of our regular business hours. So they would be run through our harm reduction program here at the county. And these vending machines would be set up with a vendor in a way that would require folks to meet with our harm reduction program coordinator or that whomever is staffing that program at the time to get a code. And then they could access a limited amount of either the harm reduction or kind of general public health basic needs supplies based on what is entered by that code. So really the intention here is to expand access to some of those life-saving and just basic needs supplies that we offer here at the health department.
Are these vending machines used in any other health departments in the area? Is there a track record on that?
Yeah, so I believe Marquette County, they're all fairly new here in the state of Wisconsin. There's a good handful throughout the state that have been operating for at least the last several months. And then the state has a wave of multiple grant opportunities. We had one through the Department of Health Services. Now there's one through the Department of Care and Treatment Services, really looking at kind of having these throughout the entire state. So it's pretty new, but there's a lot of communities that will have them. Outagamie County also got a grant. There's a few other neighboring counties that will be doing something similar in their communities.
So then, since we got left out, how do they get in?
It's the outdoor alcove. So if you walk out of our building and go to the right, in between us and the State Street Center, there's like some green area and benches and those sorts of things. So in the back wall of that alcove is where the vending machine will be. So we've been working with facility and IT to figure out exactly how that will look and be set up.
I see, so in the open air, right?
Yes, the outdoor, so they're a special outdoor vending machine that is temperature controlled throughout the entire year. So it allows us to keep the Narcan and any other contents that need to be temperature controlled safe despite our changing Wisconsin weather.
And how will you do that climate control thing?
Technology that's far above my head, but there's specific vendors that have created and built this technology out for us. So we have to work with specific like medical vending machine vendors to configure exactly how we want it.
Okay.
They're just refrigerated.
Here's what?
They're just refrigerated, that's
Oh,
Kind of like a soda machine, I suppose, right? Because that's cold when you get one.
right.
So we don't own the machines, right? We're just renting them?
We will own them.
Own them?
Yeah,
So
the
we-
grant is to purchase the vending machines.
And then we gotta stock it.
Yes.
For the years after the grant, because that we do.
So the grant covers, I believe it's 2 years, this initial grant, and then the intention would be, so it's kind of several fundings. We're part of the Narcan Direct program through the state of Wisconsin, so that's where the Narcan would come in. This grant gives us some funds to purchase some supplies to go into the vending machine. It would also cover the cost of the vending machine and the cost of the technology through the grant. And then what we would be doing is kind of looking at this essentially as a pilot for those first couple of years to make sure it's going to work, figure out what exactly we're going to need in there. Are they in the best location? Evaluate our program as we go. And then we would also be simultaneously pursuing additional grant funds to cover beyond those 2 years, which given the amount of things like opioid settlement funds and just grants available related to substance use and overdose death prevention, I do imagine that we're going to be able to continue to have those funded.
So this purchase price, that includes the first stocking or that's just for the machines?
That includes all the things for the first 2 years. That includes putting the items in the machine outside of the ones that we have through different
It
grant
includes those items.
and the machines and the technology and the vendor support and all of those sorts of
Okay.
things. Yep, it's the full cost.
Let's think about security. I mean, like breakable, I mean, I know other vendors, people break in and get how this can be.
So each vendor tells us something a little bit different, but that's one of the, given that we've brought in facilities and IT and Mandy Breger, our strategist that's been looking at this, has a list of questions that she's going through with each of the vendors that we speak to, and they all talk about the variety of safety things. I think one of the last vendors we met with said that, you know, they're bat proof. Like if somebody took a bat to it, nothing was gonna happen, so.
And this isn't necessarily a transfer, but more of an acceptance of a grant,
Yes,
right?
Yes.
Because there's no budget adjustment impact, right? Because if we don't accept it, we won't get the vending machines. And if we do accept it, it's no money out of the already money we're given.
correct.
Okay.
What does success look like? How do we know it?
So that is, I think that's a really great question, and that's one we've been asking ourselves quite a lot, because what we do know is that unfortunately, we can't measure rates of overdose deaths and use that as our only measure of success here, because there's a lot of other factors to that. We do intend to have some sort of evaluation of the program, specifically with the people that are using the services around the supplies available. But that is kind of a question that we are trying to figure out too. What we do in our harm reduction program is when we give out supplies and then people come back for additional supplies, we do ask a lot of questions specifically around like our fentanyl test strips and things on like how they were used and if there was any behavior change that came about after a positive test for fentanyl. And so those are some of the new data collection pieces that we're beginning to use as indicators to see behavior change in the program. So I imagine we'll try to figure out a way to do something similar with the vending machines as well.
Do you have the fentanyl strips in this vending machine as well?
That's the whole, yes.
That's nice.
Yep.
I'm confused how this is called a budget transfer, but what it actually is accepting a grant. Is this a budget transfer? There's money someplace in the budget that we're transferring?
So my understanding, and Julia, if you, is that this is the budget transfer is the county process for accepting a grant, because we need to add the new funds in as both revenue and the expense.
I think other places we've accepted grants, it's been written as accepting grants, it's been written as budget transfer.
This is Bev, the accounting associate, and it's actually called a budget amendment.
Okay.
So we are just adding to the budget. We're adding revenue and we're adding expenses that equal those revenue.
Thank you, that does make more sense.
And
Yeah.
it does budget amendment on the form, but then on the thing is a budget transfer.
Yeah, I believe it's a new terminology that, that finance is using. That, correct me if I'm wrong.
That is correct, yes.
It's now called budget amendment. I think Doug just needs to catch up with the.
Oh, yeah, no, that's good.
Okay, budget, okay.
So if I can get a motion for the budget amendment.
A motion to accept it.
I'm sorry, who was that?
Lois,
Gritzmacher.
and if I can get a
No,
second.
second.
All those in favor for the budget amendment, say aye.
Aye.
All those not in favor, say nay. And it has passed. Thank you. To the director and staff update. Usually we start at one part of the table and we go around. Oh, no, we follow this.
Yeah, so, I have been asked to provide a little bit of information as part of Doug's, updates on, the Department of Health Services 140 review. So if I could share my screen. I just need to bring up the presentation. Bear with me, please. Okay. Yay. Wonderful. Thank you. So the Department of Health Services 140 review, or 140 is an administrative code, Wisconsin administrative code that delineates the requirements of a public health agency like ourselves. And the administrative code is sort of based off of chapter 251, which is a state statute. These are just some of the many state statutes that sort of delineate or include requirements and responsibilities of a public health agency. So I just wanted to list the very obvious ones, but there are many more. So what is DHS 140? Because you will probably hear us talk a little later in some future Board of Health meetings about our DHS 140 review. So before we get to that point, I wanted to give you guys a little bit of a background. So like I said before, it is an administrative code. And it is sort of the principal administrative code that we go by because it's the one that most specifically delineates the requirements of a public health agency. It was recently revised, so the state recently revised the DHS 140 to align with the National Foundation of Public Health Services. And following my presentation, Heidi is going to give a brief overview of the National Foundation of Public Health Services. And the reason we're doing this is because there's lots of changes coming about with those two that we are trying to align ourselves as a public health. Okay. There you go. So what are some of the requirements for a local health department based on the DHS 140? And I've just picked on some because it's like a 3-page document, okay? So we're required to conduct surveillance and investigation. This could be surveillance and investigation on diseases. It could be surveillance and investigation on environmental health, surveillance and investigation for other data points, etc. A requirement is to work on communicable disease control and other disease prevention. So a lot of times you will maybe hear Jackie talk not only about communicable diseases, but other diseases as well. Emergency preparedness and response. One of the reasons why we have an emergency preparedness and response coordinator on our staff. Health promotion, and this really health promotion, everybody in our public health department does health promotion, right? There are some staff that work on it more detailed, in a more detailed way than others, but we all engage in health promotion. Policy and planning, another reason why we have a public health planner in Heidi Keating. And you know, in the terms of policy, we all have to be aware of what policies affect public health. We're required to have an environmental health program that includes a human health hazard control and sanitation. And you've heard from Anne many times before talk about those two programs and give updates on that. In addition to those, we are required to serve as community health strategists. So a health strategist is a staff or a program that really looks at best practices and evidence-based practices to help lead the agency in making decisions along with input in the community on what is best in terms of impacting population health. In addition to that, there is some language about addressing social determinants of health. And you've probably heard us talk about social determinants of health or maybe social drivers of health. And basically, these are like non-medical factors that influence health outcomes. So air pollution, water quality, the neighborhood you live in, how safe it is, etc. And social determinants of health also include those community conditions, like I just said before, you know, conditions of where we live, where we work, where we play that affect health outcomes. I think it comes to no surprise that sometimes our zip code has a huge impact on our health impacts. So that's basically what social determinants of health are all about. Okay, for some reason my computer's just today. Another requirement is related to organizational excellence. So it's develop and maintain a performance management system. And we are currently working on developing the department's performance management system. I had a very nice talk with Toby at our, what was that? That was at our
COVID end party.
COVID end party about performance management. Also developing and implementing a quality improvement plan, which is in process. And throughout all that we do, there's a requirement to embed public health and nursing services throughout everything. One of the last requirements is alignment with our state public health agenda. So the state, just like we, every 5 years have to go through a community health assessment. And we happen to do one every 3 years just to partner with our healthcare services because they have a 3-year requirement. The state also has to go to a state health improvement plan. And they do that every 10 years. So they just came out with their latest state health improvement plan called SHIP. And so there is a requirement in DHS 140 that says, you know, some of the things, some of the programs that we work on and our community health improvement plan have to be in alignment with the state's doing as well. Any questions? Because I'm now going to transition to the foundational public health services that I'm going to be talking about. Sure. Stop sharing for a second. Sure. Your patients. Just go there.
Good morning, I'm Heidi. I have just a one-page handout, so I'll do I have to stand up. Partly because I really like talking about the Foundation of Public Health Services, and I'm excited to share with you how our health department, Winnebago County Health Department, aligns with this national framework. So the foundational public health services are a minimum set of public health services to be available in every community in Wisconsin and the United States. So I really like this explanation of the foundational public health services. So like public safety, the fire and police, public utilities, power and water, and other public infrastructure, roads, sewers, there is a foundational level of public health services that must exist everywhere for services to work anywhere. So when you think about that, and you know, like you can call 911 if you're in Oshkosh, Wisconsin, or if you're in Bozeman, Montana, or if you're in San Diego, California. So it's kind of, public health sits in the public domain. So there's this minimum set of services and programs that people should be able to expect from public health. And so, you know, I think we've shared, you know, before the pandemic, we were kind of under the radar and the pandemic really put public health in the spotlight. But this is where we can really talk about what public health should look like for everybody, all community members to have access to these services and programs. So this framework outlines the unique responsibilities of government public health. And it shows the fundamental responsibilities of public health to provide public health protections and services. So this is an industry standard. So it's a national model, public health departments, governmental, specifically governmental public health. So we're talking about state health departments and local health departments follow this framework, this foundational public health services. Oops. Okay, so it's really broken into two parts. The foundational areas, so these are known as public health programs. They're topic-specific programs and services aimed at improving the health of the community. So that's what the foundational areas represent. And then on the other side, and this is in the bottom of the framework, are the foundational capabilities. And the capabilities are the, it's really like our infrastructure. So that support the programs and services. They're cross-cutting skills and capacities needed to support basic public health protections, programs, and activities that are key to ensuring the public's health and the community's health. So this is just to look a little bit more closely at this alignment. And so like Julia was talking about the 140, the administrative code, and that's, we have to follow administrative code 140, and we have the 140 review every 5 years to make sure that we are following everything in the code. But this is to show you how it aligns with state statute, our administrative code, and then how we have our divisions set up. So you can see with the state statute, communicable disease, chronic disease and injuries, environmental health, maternal and child health, and then the health administration supervision. So that aligns with the foundational areas, communicable disease control, chronic disease and injury and prevention, environmental health, maternal and child health, and access to linkage with clinical care. So there's the state statute that you can see aligns with that, and then also administrative code. So in administrative code is where the access to health services and that linkage to clinical services, that's one of the foundational areas that we provide to our community. On the top there, that line that says community-specific services, that's also part of those foundational services. And so what that allows for is really for our community to determine the needs, the specific needs. And so we find that through the community health assessment and the community health improvement plan. So that's where we have Ashley's division, where the community health and prevention works on the community identified needs. For example, the substance use and harm reduction, those have been identified as top community priorities. And so that this framework allows for that community to decide what is really important. And so then our divisions are also aligned with those foundational areas. And I just wanted to point out that sometimes the names aren't exactly the same. Maternal and child health, that's been used for a long time. And we have renamed it to be more reflective of, Alana works on healthy lifespans. So it's not just mothers and children, but families, and also health throughout the lifespan. So as much as we focus on mothers and children, we also focus on older adults and the needs that they have as well. So Alana's program also looks at chronic disease and injury prevention as there's overlap. So there's our WIC program works on maternal and child health, healthy lifespan and community health and prevention, work on chronic disease and injury prevention. So we have a lot of overlap, and we've renamed our divisions to be more reflective of what we need for our community and for us to work better as a department, I would say. So then the capabilities, so these are those cross-cutting skills that we need as a department. And so this is where we have, you can see that our department is also set up with the specialist role and to provide to the department these kind of support. So we have our administrative support, communications that supports the entire division, emergency preparedness, again, that supports our division and the community, epidemiology, which is critical to making sure that we have current data, and planning to work on performance management, the community health assessment, that kind of thing. And it's not that these are just for one person to do. I would say our entire department works on, there's a lot of interdisciplinary work together, and that the staff, that we are able to support our staff and they support us. So it's kind of a two-way street there, and building the capacity. So the way that our department is set up is to build the capacity of staff to be able to have the skills and capabilities that are listed here in order to best provide the programs and services.
And then one of the ways that we also ensure that we're moving these capabilities, not just for us, but also for our community, is to base it on equity, so equitable programs, equitable ways of doing things. So that's why you see the framework, equity sort of as a base of all of that.
Yeah, I mean, the equity piece, it's in administrative code, it's in this foundational public health services, and it's really, you know, nationwide looking at to make sure that we have equitable outcomes for all people. And so that's really a core value of the health department and public health in general. So just about next steps.
I have a question.
Sure.
Since you brought up equity, have we ever denied any services somebody because of their race or their gender or beliefs?
No, and I think that's.
And it seems kind of moved to.
So equity has a broader
Sure.
definition. So equity, for example, is, let's say we're looking at data and we're looking at maternal childbirth deaths. And we see, for example, that Black mothers tend to have a less favorable outcome. So one of the things that we look at is, okay, why? What is that data showing us? And we may discover, for example, that that population maybe has less access to care. So what we try to do, or what public health tries to do then is, okay, how do we make that access to care more equitable so they do have the same access as others? Maybe it's an issue of income, maybe it's an issue of distance to the nearest clinic, maybe it's a language issue. So that's a broader, much broader definition of equity.
And has that not been done?
Not traditionally in our healthcare system,
Really?
really.
Yeah, so it's not just about race. I think that's the media, kind of like race, equity. In public health, equity is so much broader. Even our rural population, right? We look at rural population, do they have access? If there's a farming emergency, how long does it take them to get to a clinic? So transportation, distance, okay, how do we make those outcomes more favorable for our rural population? So it's equity, but with a big E, not a little e. It's really, really, really broad. Yeah.
Thanks.
Good question.
Maybe going along with this, equity, I was thinking if there's if there's a mother who does not survive childbirth or dies shortly after postpartum, you talk about maternal child health. What do you do with that child who doesn't have a mother? Is somehow the father, are these kids still covered under maternal child? When there's no mother,
Are you talking about insurance and benefit wise?
whatever you're talking about for maternal health. If there's no mom,
Yes, children can come into our parent resource hours or they don't need a mother with them. Maternal child health doesn't require having a mother to
Okay.
serve the child.
okay,
That's part of the change, the name change to be more reflective of, family health. So it's not just specifically for,
Yeah,
you
we
know,
have dads come in with little ones.
Yeah.
are there any other questions? So, yes.
Just a correction and a comment now. And again, see how I say this, but because of the pandemic, we've probably learned a lot more stuff than we had before, number one, right? So that's important. I think number two is, our society kind of went to, this is all fake, whenever other doctors or certain people said certain things back and bounce back and forth. I would hope that by changing all this, that now in the new world, the way things change, we found out so much, that we're not so much depicted that someone is telling the truth or it's fake, that let's listen to both sides and understand everything. And that's where a lot of stuff's coming out that we didn't have for people. There was unfortunate people that during the pandemic or different issues could not be taken care of because of some things. So I hope by realigning this, that we got out of that thing where we're no more open-minded. I didn't know if it is more, that the more to listen to both sides, not make it political, but listen to both sides, because now as we adjust and we get out of this, we find a lot of stuff that was not fake, it was more truth. There was more things happening that we didn't know, that we kind of poo-pooed because we jerked real quick with the pandemic, that we have learned that there is other choices, there is other things, there is other options, because it all came out now. I mean, it's not at one side or the other, but there is other sides. And sometimes to jump and jerk to something that you have to change and you have to look to it. And we want to get as much data and information as we can, so to make sure that we can take care of more people that we maybe didn't because of the pandemic. And I'm just making a comment. Sounds like they're making a lot of changes. They're learning a lot of different things. And I just hope in the whole realm of it, that we are open-minded more than we were before to just reacting real quick to now like, oh, there is other choices. Let's listen to other people that maybe some people are not telling it. They're not faking or making it up. There is other ideas. And that's why I'm glad about it. That's why I'm just saying with all the changes, it seems like more things are coming out that we should be more open-minded. And I think that's important because it affected a lot of people, a lot of different ways than just real quick, there's a lot more to it. So I appreciate what you're doing.
Yeah, and so just to share like what's coming up. So just one thing is that this framework isn't new. So, we've been, working under this kind of framework for a while. And so it's really to show how this all works, right? That you have state statute, we have administrative code. So we follow that. So we are in compliance with those requirements. But to your point, I think like really trying to, engage with our community and listen to our community and to get out into the community and to hear from people is definitely where we're going, kind of in this post-pandemic, now that it's not at that crisis. So what's happening at the state level is that there's this, it's based on the Foundation of Public Health Services. There's a cost and assessment tool. So they're doing this throughout the state to really assess, like at the beginning, when I said that these are the minimum set of services for public health services for everyone in Wisconsin and the United States. So we are doing an assessment to see how we're doing with this minimum set of services. And that's what is what's coming next. So we're actually just have the tool and we're underway to completing it. It's a very comprehensive tool to look at the cost of public health services and kind of the status of providing those services, not just in Winnebago County, but throughout the state of Wisconsin.
We're not the only ones doing this assessment. It's a very robust assessment. And one of the goals of this assessment is, okay, these are the capabilities that we need for every local health department to be able to provide services to the community. Do we have those capabilities? Do we have staff with that capability? How do you define capability? Is it a proficient level? Is it a minimal level? Is it a full level? And so Bev and I actually just got done, and just got done this week, going through a demo. And this assessment is due in August, so we're gonna be really busy. And, you know, every local health department, and I believe tribal health department in the state is going through this. It's a best standard. And the idea is once we have a costing and assessment, and by costing, it's not so much costing per service, it's how many FTEs do we have? What are they working on? Those kinds of things. Assessing the capabilities of those FTEs. And the idea is to see, does local health department A have all the capabilities they need to meet the services? Does local health department B have those capabilities, et cetera? And I think, don't quote me on this, the idea is as a public health industry as a whole, so as a state, assessing all of the local health departments in the state and saying, wow, as a whole, we have a gap with meeting this capability because we don't have enough FTEs, or we may have FTEs, but their capability might be at the proficient level, not at the expert level. We need to, raise that up.
For an example of that, like, so we have Shelley as a full-time position in emergency preparedness, which is fantastic. And a lot of health departments have, say, a health educator that also does preparedness. So they'll have a position that is part-time preparedness, part-time health educator. And so, but during the pandemic, we really saw how critical that position is. And so that's like, looking at all these positions and being able to provide those services.
So that's what's next. That's what's gonna keep us busy in June, July, and August. But everything is coming together. So the alignment of our statutes, our administrative code, the industry standard with the foundational public health services, and then this assessment. So we know we kind of just rushed through it. It was just meant to be as an overview. Later on, I think in 2024, I don't have a date yet. The state will come and basically audit us. It's called the DHS 140 review. Basically, they bring up that administrative code and they go, are you meeting this? Are you meeting this? And we have to provide documentation, rationale, basically write a report showing how we are in compliance with the DHS 140. So if you hear us talk about, especially maybe Joshua, who's new, DHS 140, what's that? That's what it's all about.
How long does that process take?
How
When
long?
the state comes, yeah.
I think it's only like a day.
Really?
Okay. But
Takes
in
us
the
a lot longer
meantime.
to prepare for
Yeah.
it.
There is like a 50-page document that Heidi and I have been working on. And there's a set of questions. And the questions are broken down by abilities and services. And so there's a series of questions for each focus area, for each foundational capability. We have to provide documentation, we have to provide examples, all that. So it really is a department-wide effort, but Heidi and I sort of lead that process. And so even though we don't even have a date for 2024, we're already meeting almost on a monthly basis, twice a month, to just go over the set of questions, because they do send us to us before. So I don't know if I can answer your question because it takes a whole year.
So in your last review 5 years ago, were there any deficits, and have they been fixed and met? And
Yeah, good question. So we were due a DHS 140 review in, I'm gonna say 2020. And if you recall, that was in the middle of COVID. It was October of 2020. So the state, being flexible and listening to their constituents, which is us, right? The state, local health departments, we were COVID 110%, they said, you know what? We're gonna do an abbreviated audit, and it was by Zoom. They sent us an abbreviated set of questions, which I worked on with input from the staff. We presented via Zoom, and they were incredibly impressed. So,
Yay, you.
well, no, not yay me, yay us, really, yay us. So they were very impressed with the documentation we provided, the examples, how we were in compliance, and yeah.
Thank you.
That's all I've got. I'll stop sharing my screen. Thank you. Really good questions.
Then do we move on to Anne?
Sure. So environmental health updates for this month, for the lead abatement program, we purchased a new lead analyzer, a lead paint analyzer for the program, and it doesn't rely on the radioactive source. It's an X-ray machine. So we no longer have to have a radiation safety officer for the department. And the rules are a lot less with storing it and transporting it. So that machine, it's called a PSYOPS, and it's an X-ray machine. The readings are like almost instantaneous. With our old XRF, we would have to hold it up against the wall for about, I don't know, 5, 10, 15 seconds before we got a reading. This one we put against the lead paint, but we get almost an immediate reading. So it's decreased our inspection time on our lead projects immensely. So we're excited for that. All the staff have been trained on that, so that is good. Currently for the lead program, we have 19 properties approved through the state or by the state. We find the properties, they have to do the final approval on them. 4 of them are currently under state review and 2 have been completed and 4 are, I think, out for bid right now. So that program is moving along really well. For our environmental health section, we started our beach and boat launch weekly water sampling. So we test in partnership with UWO, the students at UWO collect water samples from about 10 boat launches and beaches throughout the county, through the whole system, the lake system, just sampling, just to find out, you know, how the water is at weekly. The results are posted on our website. We do have the beach at Menominee Park that's tested twice a week. The beach in Winnebago is tested twice a week, and then the beach in Fresh Air Park up in Neenah is tested twice a week. And then it's posted green for good, yellow for caution, red for do not swim.
What's the beach in Winnebago? The pool?
No, it's the one on the lake, one of the lakes, Lake Winnebago.
Well, like a
Down
county
at the
park
north
there.
side,
Okay.
yeah.
County Park.
I've never been there. Okay. Thanks.
So that's the one that's tested. They are posted. The UWO does all our testing for us. It's a student internship for the lab, so it's a good partnership. Students learn, it's a good partnership with them. And then we do have a lead and water testing grant for daycare programs in our area jurisdiction. So we tested 4 daycares for lead and water. The results came back on 3 of them with no lead found in any of the water at the 3 daycares that we tested. We are waiting the results of 1 daycare yet. And then we have 3 or 4 other daycares that have expressed interest. We're contracted to do 10 daycares by September. So hopefully we can get some more interest in it. What happens is we test for lead. If there's lead found, the state hires a plumber and the plumber will switch out the faucets with new lead-free faucets if that's what they think the issue is. They'll switch out the bubblers if the bubblers are old. And that's all paid for by the state grant. And then we would go back and retest that water to make sure that that solved the problem, that there's no lead in the water. So far we haven't found any, so we haven't had any to do any remediation on it. So good, that's good. And our sanitary program, we've had, I don't know if you guys want to know the specifics, but we've had a couple change of owners in restaurants and a hotel. And then we've had some new establishments. We've had 3 mobiles, which are Bread and Butter Catering, Golden Gourmet Waffle Sticks, and Pelor's has a new mobile unit. And those were Fox Crossing, Town of Neenah, and Oshkosh. We have a couple new restaurants, Noodles in Neenah, Dunkin' Donuts in Oshkosh and Tukwila in Oshkosh. Quite a few tourist rooming houses, which are Airbnbs that we license. One in town of Black Wolf, one in town of Winnebago, and 4 in the town of Amro. And then we had a couple retail food licenses. We had Kim's Farm, which sells meat from his farm. And Yeti Yums, which is a dehydrated candy business. They dehydrate like Skittles and Taffy. They put them in a dehydrator and they sell them, and I guess it's a big deal. I don't know. So,
Sound good.
yeah, they do Skittles, they do M&Ms, caramel M&Ms. Skittles. They do sprees and sweet tarts, and they put them in the dehydrator.
You gotta get really tiny.
The Skittles get really big and they crack open.
Oh, really?
Yeah, and they like melt in your mouth.
Okay then.
Who would know? It's a big deal, I guess, on TikTok or something.
So we're really trendy, is
that
Yeah. We still have samples.
Exactly. So those are the new establishments. We're working on finishing up our inspections for the year. They have to be done by June 30th. I think we have about maybe 25 left, so we'll be good. And then the renewals for the licenses were sent out in May with final notices sent out last week. The renewal fees are due by June 30th. So we had quite a few out. We probably had a couple hundred that haven't paid yet. So a lot of people, you have the two groups, the ones that get the renewal and pay right away. You know, they want to get it off their plate. And then we have the other group that we're not giving the money to the county anytime soon. We're gonna wait till the end. So, and then there's the ones that will pay after July 1st every year. And it's just the way they do business and they get charged a late fee.
You charge what?
A late fee.
Fee? Oh.
It's just the way, and it's pretty chronic. It's the same people that usually pay late every year. You can count on it. So, yes, we'll be working on getting those. And the last week of the month, the ones that are still outstanding, we do give them a courtesy call saying, hey, you know, your fees are due. A lot of them will say, yeah, I'm bringing it in, I'm bringing it in. But we don't want to charge them a late fee. You know, we give them every opportunity to pay. And there's just some people that want to give us extra money. The late fee is $157, so it's a chunk of change. Some people's licenses are only 160, so they're paying almost double. Yeah, so that's what we'll be working on the next couple weeks.
You guys send out a lot.
Yeah, well, yeah. It's a lot.
You send out.
All the food trucks that are out on Saturdays at the farmer's market, those have all been tested. How often do you test those, or?
Most of them, well, I shouldn't say most of them, a lot of them are licensed by us, so they get their pre-inspection license, and then we inspect them during the year. Some of them that come out of other cities, they're inspected by the other city, and then we will catch them at the farmer's market. Usually once or twice a season, depending on where we see them.
Okay.
Or if we get a complaint, then we go right away with a complaint.
My complaint is long lines.
Yeah, I'm sure. I mean, like I said, we have 3 new food trucks coming out, so we get calls at least 3 or 4 calls a week about wanting to open up a food truck.
Will it be a food truck of dehydrated Skittles? I'm really.
There you go, you never know.
It needs to park on the front is what you're saying.
Like Karen's house.
Maybe you need to go to, what is it, Friday, Food Truck Friday?
Yeah, that was last week.
Yeah, maybe they'll be there, I don't know. That's a lot of fun.
Okay, thank you, Ann.
Thank you, Ann.
Ashley.
Thank you. So I'm going to talk about the Community Health and Prevention Division. In May, we welcomed Rabia Wahid, who is going to be, or who is our newest community health strategist. She will be overseeing our Drug-Free Communities grant and the Breakwater Coalition. One of our other strategists, Maddie, just completed Parents in Recovery listening sessions, which is part of our social connection work and our supporting recovery work. So they are moving into the data analysis piece. So I'm thinking likely by the next time we all meet, I'll have some information for you on what we learned in those sessions and how we will move forward with that information. The COSAP grant, which is that $1.3 million grant from the BJA, that is doing a lot of our substance use and overdose prevention work, and is currently funding a good chunk of the Solutions Peer Response Team, is still moving forward. The Solutions Peer Response Team in the last 9 months has served 675 unique individuals with a total of just over 3,100 contacts. And in the Winnebago County Jail alone, they've had 540 contacts. So that program is really taken off and looking to expand. They've been doing that kind of peer recovery work, those sessions, transporting people to detox treatment centers, meetings, getting them hooked up with various providers. So pretty excited about that work continuing to move forward. Internally in our harm reduction program, we were able to get our hands on some xylazine test strips. If you're not familiar, xylazine is one of the newest and unfortunate drugs that we're seeing in our community. It is a horse tranquilizer, is what its intended use is, but it's now being cut into a lot of our different substances that people are using in the community. It's scary because Narcan is not effective for it. It's not an opiate, and it causes sores throughout the body, ulcers, yes. That can be pretty bad. So we're trying to get the word out that xylazine is out there and for folks to be careful. So we were able to purchase a small amount of xylazine test strips so that we can give out to our harm reduction clients, and just to help them understand that it's here and figure out what substances the xylazine is in. We created a brochure about xylazine and how to use the test strips that we're giving out to every person that we see. So I brought some extra copies in case anybody wants some additional information about xylazine.
Can I ask this? So is it a drug that people are taking because they want to, or is it something that's being a filler in a different drug that they think they're taking?
It's yes, it's a filler being cut into substances like meth.
Okay, so no one's saying I want this drug. Okay.
That's the likelihood is that not, yes.
I do have a question following that too. So the fentanyl and the xylazine, as they're just adding to it, the purpose, I'm assuming, is only to cause harm, right? There's not a high specific that you're gonna get from this as you use as a cutting thing, or is that a mistake?
So so I think that the reason, from my understanding, that substances like fentanyl and xylazine are being cut into other substances is because the high can be quicker and more intense, especially for the fentanyl, and then it burns off quicker. And so it spurs on a need for more continuous use, is my understanding. Now, I am not an expert in how decisions are made about what gets cut into.
That there is causing all these tests.
What was that?
It must be a fine line that gets crossed that causes these increased tests, that I'm assuming.
So fentanyl specifically is one of those substances that there's like 20 different types of fentanyl, and it's just kind of like a micro dot of fentanyl can be that thing that sends a person into an overdose. And so what happens is it gets cut into a substance and nobody knows exactly how much is in each substance or whether it's in that specific shot. And so that's where we're with fentanyl seeing so many overdoses.
Thanks.
I also add that like fentanyl can be manufactured much cheaper and quicker. So as people looking to make money off this system are doing it, other countries, other states, they're trying to supplement for a cheaper way and still, keep that income coming to them. So.
Yes, thank you.
Muscle relaxant, central nervous system depressant, cause drowsiness, is this a date rape thing? Is it used for that? No.
I mean, its intended purposes is an animal tranquilizer. It's a
I know, but whoever they're making it for, whatever they're making it for, they're not selling this stuff we don't care if they're tranquilizing it courses. we're worried about what happens when it gets into the local
Yeah.
population.
Yeah.
When it's in the local population, is it used as a date rape drug?
That
And you're saying no.
I've never seen that. Yeah.
So that's kind of our newest hurdle that we're trying to get some prevention around. The other materials that I have to share for anyone that is interested is the new mental health connection in partnership with the health department did a Mind Your Wellness survey in 2021. And then there was a group of folks that looked at that data and came out with some community mental health recommendations. So this is mental health and suicide prevention recommendations that was just published within the last month. And we, as a health department, held the qualitative data grant from the Department of Health Services. And we were really looking at evaluating the Go Transit program that was offering free bus rides to kindergarten through 12th grade students in the city of Oshkosh over the last couple of years. So we utilized those grant funds to partner with the Whitburn Center at UW Oshkosh, and they did the qualitative data analysis for that grant. So this is the report that was developed based on that work, which was primarily led by our epidemiologist.
Thank you, Ashley. And we don't have Jamie here today.
I just wanted to put a note in there that Wisconsin has finally decided what style they're going to do for their WIC visits, and that is going to go back to in-person in August. They have stated that they will allow virtual for those that can't transport, but we're hoping that people start coming back in so we can get eyes on families and build that relationship up again. So that's what I wanted to share for WIC and Jamie.
I think I'm next, and I'm gonna let, do you want me to just, okay, so, our team is made up of emergency preparedness, planning, epidemiology, and communications. So with emergency preparedness, cooling locations, we may not need it today, but a week ago, we did. So those locations, or the list of locations, have been confirmed on our website for 2023. And for now, it's our public libraries. Our public libraries are such a community center for so many things, so. Free antigen test kits, they're still available at while supplies last throughout many locations in our county. The state emergency preparedness plan has been sort of updated or tweaked or refreshed to include COVID information or post-COVID information. And those changes will reflect, those lessons learned, like Ralph, you mentioned, what are some lessons learned from COVID? So I think, throughout the state, you'll see these plans start to be inclusive of what did we learn? Were we actually ready? Those kinds of things. Even our community health assessment, included some questions about how has COVID affected you, et cetera. So all of these will be more closely aligned with public health accreditation ready process, which we haven't talked about in this meeting yet. And the county plans are going to be updated once the state plans are updated. But you're next.
Well, one of the main projects I'm working on is the community health assessment, and that is a requirement. And for health departments to complete every 5 years. And so we are just really trying to complete the draft right now. And then we'll be able to share and get feedback before we have it finalized.
And I know that Heidi's also completing some focus groups.
That's part of the community health assessment that we have to collect primary data. So we've been having focus groups and just talking to people. The most recent one was over at Day by Day, the warming shelter, and talking to people that are homeless, experiencing homelessness, and just, have a chance to hear about, what it's like to live here and things that they are struggling with. So it's been really insightful, and we will include the themes from those focus groups in the community health assessment.
Our epidemiologist, Sarah Jean, is very hard at work. She is also an integral part of completing the community health assessment because an assessment requires data, and Sarah Jean is sort of our data expert. And she has also been very instrumental in learning how to use our new performance management system. Heidi, Sarah Jean and I are sort of the first 3 staff that are being trained. But Sarah Jean's mind just works differently than ours, and she is really getting into it, and it's lovely. So we're just really just starting with that process. So that's sort of our updates, with the last one being from our communication specialist, Ashley Mukasa. And she asked me to share, can I bother you by passing that around? Share the annual report that she has been diligently working on. And that will be sent to the state. Again, one of the requirements of our DHS 140 is we must develop an annual report and submit it to state. That's all I've got.
All right, so communicable disease. Public health emergency added May 11th. Now we're looking at hospital admission levels as opposed for community levels. We continue to offer COVID vaccine while supplies last, but we know that that's going to probably be commercialized coming up this fall. We do have to keep it available on site for our vaccines for children program. So that will be available in all combinations because that is part of our immunization requirement, and that's on the AICP. We have a resurgence of monkeypox, mpox, and we've seen that at events down in Chicago, going Gateway and the highway system, going up to Fox Valley area. We are prepared if we see more of that. We have offerings. We do have vaccine available for those that feel the need for that. In recent months, we have worked a little more with our local healthcare. Most recently, it's been Aurora, leading with the emergency department, urgent care, and occupational health, building those relationships, knowing that when those communicable diseases that are class 1s and things that come in, they are more prepared, for handling that. We work together to take care of those, and those meetings have gone well. And it was actually very well, very nice to get back into some of that and build those bonds again when we had been apart for so long. Anybody have questions?
All right, for the Healthy Lifespan Division, we have resumed most of our services that we provided pre-COVID and doing quite well. We had Lindsay Euchre, a public health nurse, start this week. She comes to us from the Oshkosh Area School District, so we're very excited for her to be able to expand that engagement and relationships that we found so critical during the pandemic. This will also help us take care of the referrals for older adults that have been coming in. Teresa Paul is retired in February. We hadn't replaced this position until now. So we're getting more of those referrals from Human Services, ADRC, where we step in and help with that medication management, falls risk, those home visits that are needed for those older adults in our community. We're also supporting the day-by-day health education programming. So based on their model to have beds, they can participate in daily programming, and they've tapped some of our staff to come in and talk about specific topics. And we're starting with women's health. They've seen an increase in that population recently. So we're helping them with that. It's a good partnership. Our Wellness Plus classes are back in full swing. We saw really great numbers come through by the end of 2020. We had over 400 participants, 5 different communities, 10 different locations. Some locations repeat their classes throughout the years, others just have one off, but they're expanding and doing well, and we're recruiting new leaders. In the family child health area, we've really been focusing on the child care center of concerns. It's been a national, statewide, regional issue. We have a lot of partners in those efforts. The Dream Up grant for 75 grand that we received with United Way, those funds are finally being allocated. They need to be spent by August. So we created an application where centers could apply for support on infrastructure, other needs, One example is we did radon testing for about 30 centers, and 2 of them that saw high rates were able to apply for mitigation systems, so that didn't fall on them. The state's requiring radon testing and mitigation, but there was no funding to go along with it, so we filled that niche there. We're resuming the lead screening services for young children. The test kits and stuff all expire, so during COVID that had kind of stopped and we weren't sure if we were going to restart, but this will be coming out of the MCH grant that we manage, and now children can come in for a free lead screening. We will promote it during WIC visits and our parent resource hours for those that it's appropriate. We still want kids to be doing this at their pediatrician's office on time. However, if we notice that there's a gap or it looks like someone hasn't been tested appropriately, we would highly suggest that. And the Wisconsin Well Woman Program has been short our bilingual staff. Luckily, we still have other staff that have been able to fill this niche, but next Wednesday or 2 Wednesdays, June 28th, we have Araceli Aguilar starting, and she is from our community, a longtime resident, and knows the connection. So we're very excited to welcome her aboard and get her trained up in the Well Women Program. Any questions?
What age level does the Well Woman program cover?
Currently, it's 45 to 65, and the state is lowering that to 40. So that hasn't been official. We're assuming it's going to be in the fall that they encourage that. Also, women that are at high risk or have abnormal concerns can go down to 35 as well, so long as the doctor specifies that, yes, I want a mammogram.
The 65 is the cap.
Yep.
Any questions before we move on to income statement? So you should have received the May income statement as well as one of the things that Synergy does so well for us is not just data collection and analysis, but visualization of data. So she puts a very nice one-pager handout, sort of a income statement summary. So you can follow either one. As a whole, we are pretty much on par, where this income statement reflects the first third of the month. So the month of May hasn't closed yet. So, and revenues, if you remember, we always say tend to lag by about a month at least, because billing doesn't occur until the middle of the following month. So our expenses seem to be right on track. If you have any questions about where we are. But
Can you remind us again of why the overall budget is a deficit? $766,000, just. I'm looking at the summary page. That we're planning on being deficit of 766, is that normal?
where are you looking at? Sorry.
I was looking at the summary page.
Yep.
It's the first kind of section there, it says yearly budget, revenue 6 million and expenses 6.8. So we're planning on having a deficit, is that what that's telling us?
So, are you talking about like the comparison of 32% to 20%?
The next line down.
Or the third, yeah, the third line, second column, or third column, second line, third line. It just says $776,000 deficit.
Yep. I think that's also in part reflected because our revenues are not, our expenses are sort of up to date, but we haven't because the revenues lag a little bit. So they're not reflected in this income statement because, I think the month of May closes today. So when we, printed this income statement last week, it didn't.
I think your question is that we're planning to have a deficit. Like the first line is our actual that shows we're at a deficit, and that would explain that. But why is that correct?
That's
What you're
right, yeah.
asking?
Why are we planning on it?
Yeah.
I don't know.
Is that what's intended to?
This is Bev again, the accounting associate. I think what that is reflecting is the $800,000 we have in the general fund. So we budgeted to be able to use the general fund. So that is why the revenue is not as much, because we can cover that $800,000 of expenses with that general fund money.
Thank you, Bev. That's great.
Thanks.
Any other questions?
The only question I'd have is, on the new budgets coming up, and there's 2 different plans now. I'm just curious how you guys are doing, because they talk
Are you
about,
talking about the priority-based budgeting?
yeah.
Yeah.
I know they
So-
referred to the old one, but then they're trying to do it.
Yeah.
I just how that's going.
Yeah, so I can't speak for the county executive's office, right? So about, I don't know, maybe a month and a half ago, we were informed that this priority-based budgeting was coming up, and there were some to-dos that we were responsible for. And the priority-based budgeting is a process, it's like a 4-phase process. The first phase is basically, we need to list all the programs that we have in our departments. And how they define programs is kind of interesting. We've had to do, all departments have had to kind of rethink how they define a program. And so we were getting training on that because there were lots of questions. And so we got done with that, and we met with Paul Kaiser, I believe is his last name, in finance, and he reviewed our program inventory, and it was fine. The next step was supposed to happen about 2 weeks ago or a week ago. And the next step is basically costing those programs. And then the following step is prioritizing them. I think, again, my perception and what I've heard is there were so many questions about this program and how to do it and the timeline, that I think the county executive said, you know what, we're gonna extend this to be a 2-year program, because it's obvious that we can't get it done in its entirety this year. So everybody's kind of breathing a sigh of relief, like, okay, let us learn this really well, let us do a good job, et cetera. So I think, to the best of my knowledge, we're going to go through the sort of the traditional, regular budget process for this year, while we learn more about PBB and all the stuff that we have to do. So that's how I understand it, Ralph.
No, that was interesting, because I learned, I know the inventory is first, but I was curious when you get to priority, because that's kind of what the whole premise of the whole thing is, to have you look at everything you got, find out which you really need and which one's not functioning, and which you put more money towards something that's really working as opposed to not.
Yeah.
And it doesn't sound like we're that far.
And I don't even know if
That's what it's
that's-
gonna be interesting.
Yeah, and I don't even know if that's what they mean by priority. We haven't received the training on that phase. I know that they talked about priority also as what geographical area in our county does the program reach? Does it have a reach? Are we not reaching our rural populations, for example? Are we not reaching our more suburban, so I don't think priority is based just, how I understand it, based on, is it working or is it not working? It's also looking at, again, equitable reach, right? So we haven't even received training on that yet, so I can't even speak on that.
Okay. This is the first time I heard they kind of backed off, because I heard everyone talk about it, when I asked about it, so, well, we're getting inventory under, we're doing this, but I don't know, but it's gonna probably be a couple, 3 years, I know.
Yeah.
And they finally decided.
That's what I heard.
That's right.
So, that was what I was informed, that it's gonna take probably for next year, we'll probably use a PBB, but I think everybody was looking for just more context and more training and to not be so rushed for this year, because I think that with the stress, everybody's stress level just got way up. So I think slow and steady is gonna be really good.
Thank you.
But again, that's my perception as the person with Bev who's been working on this, I'm not speaking for the county executive office.
Looks like we're going to have a communicable disease division overview.
So the communicable disease overview was given 2 meetings ago.
Oh,
I think we just had a memory lapse and we put it in there. So in lieu, one of the things that we're trying to do with every Board of Health meeting is not just go over business items, but also provide you with an informational section or an educational part. So as you learn more about public health. So as you recall, there was an administrative overview. Alana did her overview, Jackie did her overview, Ashley, and so at every Board of Health, we try to bring in a little educational component. So in lieu of the communicable disease overview, which was already given 2 weeks ago, or 2 meetings ago, and Joshua, we can send you some information on all of that, so you learn more about each one of our divisions, sure. That's one of the reasons why we decided to incorporate a little bit more about DHS 140 and foundational public health services as part of the director's update.
very good.
And one more thing again, I don't, after the pandemic, we talk about all the stuff that happened, and it's kind of ending. I've had a lot of friends lately that I talked to that said, I had my shots, but now I got COVID real bad. I got COVID the second or third time. I just wondered, at the end of all this, is there any statistics or information you're going to get about post, everything after the end? We always hear about what happened, but now I'm hearing more and more of my friends that had shots, getting real sick, but they're not the death sickness, but they're real sick. Or they're in a hospital for a couple of months or something like that. And I didn't hear that before. And it was people that had shots and that. So I just wonder if that information is out there, or that, post stuff that we're gonna hear about people with vaccination. Because I keep hearing for some reason that they say the majority of the people that are dying now, the ones that didn't get COVID, that did not get the shots. But now I'm hearing a lot of people, I think I just read in the Herald, a couple who just died from COVID and they had their shots. So I'm just wondering if there's that post information, because a lot of people ask for that. They want to know what's really happened afterwards. We kept track of what happened during, what about after? What about the people that didn't have the shot? What about the people that did have the shots? What to look for, risk and stuff like that. Are we doing anything like that?
Are we specifically doing anything like
In the
that?
county, or
No,
keeping
there's
track?
data out there, and yes, we're pulling that. We always do look at that, and that's part of our epidemiologist does.
Okay.
And you look at it overall over time. This is still expanding, and we'll be watching it. But you're looking at, it's a numbers, and this is why you have a data person like an epidemiologist. When you have of that older population, if you have 95% of that population having been vaccinated, well, then the largest number that will have been hospitalized and dying makes sense that there, because they make up 95 out of 100 people. So. But on the flip side, we do know, and it's evolving, that there are different combinations of COVID now. It has evolved, and that will be updated. It looks like there's reports looking at updating the vaccine to encompass more of the new combination of COVID that we're seeing out there, not the original strain.
And you can get that. All is it?
Yeah, that data is all of the CDC, and that's all online in DHS, yeah.
For Winnebago County too?
Winnebago County, yeah.
So I didn't know that.
Yeah.
People already asked me, is anyone keeping that? And I didn't know, so that's why I asked.
It's all easily pulled data, yeah. They look at it, but again, you're looking at it with an eye of, it's a numbers. And when you do have that many percent that are vaccinated, what does that really mean? Yes, Josh?
In regards to monkeypox, what population typically gets that? And then, are we, I guess, worried about people traveling? And I don't I guess, I think about a homelessness population and them traveling here. Are we worried about that group being here and bringing that, or are there other groups that we should be worried about too? I guess,
Biggest-
what's the
The
population?
biggest concern, is the MSM, men having sex with men. Are we looking at the homeless population? Not as much. Big concern is summertime. And we're in a northern climate. Summertime is is festival time. And people thinking that, okay, they're getting together and traveling. And knowing that we're a corridor, we have a lot of festivals. So, yeah, that was a concern. That's what we're looking at. We haven't had any in the Fox Valley. So, but for a long time, since last year, but we're still prepared. Yeah.
Could I go back to the COVID topic again? There is another booster that's recently come out and was made available. Where are the best places to get that?
The easiest place to get that are pharmacies,
Pharmacies.
because you make your appointments, but we also have it still available here.
You do?
We have walk-in Tuesdays,
Okay.
which we are discontinuing, because the number of uptake has dropped significantly. We just don't see any. So it'll be if you call, make an appointment, we still have it.
And that could be part of the reason that there are cases still popping up. First of all, the COVID mutates. We've got so many different types of it now that we didn't have before. Plus, older people are susceptible because granted they got a shot, but that doesn't mean the same thing for every person. Older people don't have as robust of a immune system.
Response.
So they're not going to respond to that shot. Everybody doesn't respond to it. And that's where your protection actually comes from, is how you respond to a shot. And, now the last booster is out, but people aren't getting it. So of course, we'll have more disease.
Yeah, I know that there was a lot of the people I know that had their shots, they stopped them now. They said, well, I got COVID a couple of times and all. And again, they have the wrong idea, that they think they COVID will stop. I have.
Yeah, they look at it too black and white.
Right, yeah.
It's like, I don't want COVID, I'll get the shot, I should be okay. It's never that simple.
No, but that's why I said when you're talking about education information out there, they're out there and I hear that, and I'm an older person, so I'm with a lot of older people, but they're all saying, oh, I'm not getting shot anymore because it's not doing it, so
Yeah.
they have no idea. So I mean, that's where, you need more education, more information out there. I mean, I think last time we were like, it was only 65% of people really got their shots. I think you said 95%, but that's.
No, that's just the number I pull out. I have no.
Oh, okay.
I just looked back.
There's an example.
There was an
Yeah.
example. Thanks, yes.
I thought you
Easy
said
numbers.
that.
Yeah.
No, I didn't know that. That's pretty good.
The beauty of public health, which is an intersection of art and science, is that we look at population health, right? So each one of us may have a friend or two, or even 3 or 4 that got COVID even at having the vaccine. Those are my 5 that I know, right?
Yeah.
But in public health, for us to make decisions to impact the whole community, we look at data at population level data. So, there might be a difference between what I'm hearing from my neighbors or my friends and what's actually happening at the population level.
Couple of things for you. COVID test kits are still available at all of the public libraries in the county, the community centers, senior centers. We really promote with the senior centers, the test kits. So anybody's got a sniffly nose, please swab yourself and find out what it is. And then just act appropriately. They're free. We're gonna give them away as long as we have them. But that's the part, the population we're targeting is the senior centers and folks who are more vulnerable to get those free kits. Hometown Pharmacy is an awesome partner for vaccines for anything. So if you're looking for something, I would start there. Super accommodating. Not that I'm promoting, but
And the vaccine is
they're an
still,
awesome partner.
the vaccine is still offered free, or are we looking at insurance?
For now, keep watching.
For now.
And the kits, they have expiration dates. Are they still good after the expiration date? Like a month after, or like, do you have?
The
to-
actual vaccine itself.
No, not the vaccine.
The kits.
kits.
Yes,
The
they
test, the test.
So what you can do with the kits, you can look on the kit and look up online. So we have iHealth out there and you see the expiration date. You can go on their iHealth site type in the expiration date on their list, and they'll tell you what the extension was. Every one of these companies have extended 3 months, 6 months, 9 months. I think the last I heard is now it's, we're gonna give it an extra 12 months. Unofficially, a technician at one of the companies told me, if you see a control line pop, the kit's still probably viable.
Okay,
Is that something I promote in a newspaper article? No, but if I've used an expired one myself and got a nice purple control line and didn't have COVID, but
Art and science.
no. But I'm gonna go with that.
no, that's good to know, thank you. Any other questions? Then it looks like our next meeting will be August 18th, unless something vital happens and Doug needs a July meeting. Any Board of Health reports? Nothing. And so can I have a
Move adjourned.
motion? Thank you. May I have seconds? And Jeff 1, Ralph 2, and all those in favor?
You had to ask.
All
I had
those,
to ask.
no? Okay, thank you, everyone.
So they make your heads fit?
Thank you. No.
Not yet?
We're not. We're not.